So I'm Ann Polakowski. I'm a clinical program manager with the state of Nevada, DCFS. And in Nevada, the state runs the mobile crisis response teams. So we are state employees. Our objectives are similar to what you've heard from other states. We are seeking to keep our youth in their home and community. We are looking to reduce admissions to the emergency departments because of behavioral health reasons. We facilitate short-term inpatient psychiatric hospitalizations when that is warranted for youth safety. And we are assisting families in accessing and linking to ongoing supports once they are done with us. We want to respond immediately to children and families, reduce emergency department visits, provide services that are family-driven, culturally competent, and in line with our system of care, principles and values. We work on safety, and we facilitate linkage through child and family team process. So the history of our mobile response in Nevada. It sat on our Clark County Consortia 10-year plans for a long time. And it was written into our budgets more than once and was cut from our budget more than once. And then what happened right around 2012 is we had an emergency department crisis in Clark County where our beds, both for adults and for youth, were being filled up with youth presenting with behavioral health crises. And so our emergency department started to push back on the community saying, we need something because we can't treat broken bones. We can't treat these things that are coming into our EDs because our beds are full. So in the spring of 2013, we started work groups in Clark County. We started meeting with our champions, the emergency departments, our parents, our school district, our police departments, and started our planning. So unlike some of you that have had lots of time to plan and lots of focus groups, we had about 4 months, 5 months. So spring of 2013, November of 2013, I hired 5 positions. So 2 teams working 1 shift in Clark County, 5 days a week. In 2014, so we had about 2 months with 5 people and myself and the community to plan what our mobile response is gonna look like. In January of 14, we got our first calls through our hotline. Summer of 14, because it was a success, we got more positions. Washoe County, which is Reno, started planning. In October of that year, they hired, and you'll see then by 16, we are 24/7 in Clark County, and we opened in the rural. So within 2.5 years, we went from 1 team, 1 shift, 5 days a week to 24/7 in Clark County and the rurals. Reno looks a little bit different. So we do have statewide coverage. Reno, you'll see up at the top. Las Vegas is 24/7. We also run the hotline for the rurals because of staffing issues in the rurals. And then the rest of the state is run by our rurals through telemed. Some numbers, we've served over 5,000 youth. We've hospitalized about 14% of those youth for safety. And 86% of those youth we have stabilized with a safety plan and been able to keep in the community. We also changed our language a little bit to hospitalized for safety. We used to say hospital diversion rates and got some feedback that people didn't like that term, so we're still playing with it a little bit, but now we're calling it hospitalized for safety. Our numbers over time, as you can see in our first year, we had 956 calls. Our year to date, we are up to 2,816 calls on the year. And that I pulled these numbers early October, so they're a little bit dated. You will see that initially we responded to a lot of calls, and that has kind of stabilized over time with the number of calls, although with the number of responses, even though our calls have gone up. The reason for that is as our number gets out, it gets utilized for things. In the beginning, it was very streamlined. People called us exactly knowing that they wanted us to respond. Now we are getting lots of calls for adults, for resources, for my gas is gonna get turned off, how do I? So we're getting a lot of calls that are more case management type calls or adult service calls. So we are getting calls from all 17 counties in Nevada. Who refers to us, emergency departments, schools, family, law enforcement, child welfare, community. So we're getting calls from just about everybody. Yeah.
Does that mean that kids are showing up at the EDs?
Yes. Yeah. So more so in Clark County in Las Vegas than in Washoe and the rurals. In Clark County, we have a lot of kids still responding to the emergency departments. We are really trying to figure out how we get to them sooner. Part of what's happening is law enforcement does a lot of legal 2000s, which is an involuntary hold. So when they respond in the community, they are legaling the youth and sending them to the emergency departments, and then we are getting them there. So we're doing work with law enforcement. What we get back is we don't have time for you to get here. We don't have that half an hour. We need to move to the next call. In Washoe County and Reno and in the rurals, they are not seeing that same phenomenon that we are. So we're not quite sure how to fix it, but we know it's a need to fix. What we have fixed on the emergency department side is they know how to reach us, and we are responding within the hour and a half, as opposed to 2-3 days that it was taking prior to us starting. So we have worked in that to help there. Okay, so here's how we work. We do not have a call center. We have our staff who are working on lines and doing the responses answer the phone. So for those of you that don't have a big tech system as you roll out, don't be alarmed. We have a cell phone that we answer our calls on, and we are still trying to figure out how to waterfall that cell to get more calls coming into multiple phones at the same time. So we answer and we do an intervention screening tool. That's the screening where we are hearing what's going on, what the family or the caller is asking from us. We're getting the demographics. We're asking a couple of safety questions like, are there weapons in the home and are they secured? Are there animals in the home? And how many people are going to be there when we show up, so that we don't think it's just the parent and then an uncle comes out and startles the team that we didn't know was there. So we're asking those things. Sometimes we're providing the support, a team is dispatched, or we are providing a community resource for calls that are like those case management, physical needs that people need. When we respond in teams of 2. So a mental health counselor, which is our master's level licensed or licensed intern, and a bachelor's level psychiatric caseworker, and we are responding at the family's choice, so where the family wants us to respond. The only exceptions to that, of course, are if they're in the ED and the doctor's not going to release them, then they don't get to choose where we go. But we do allow the family to say their setting of choice. During that response, we do a structured assessment of the crisis assessment tool that we talked about a little while ago, and our psychiatric caseworkers do a crisis needs assessment. It's an assessment in which we are looking at the whole family across all their domains to see where their strengths are and where their needs are. And it's during that assessment where we often find out that their rent is past due and they're about to be evicted, or there's no food in the house, or who their community supports are. During that response, we also do a safety plan, always. So even if we know that the youth is going to end up going to the hospital for safety, we still do a safety plan, because that youth leaves the hospital. And they leave that hospital without a safety plan a lot of the times, so now this family is going to have a safety plan. So at the end of our assessment, youth go one of several ways. Some do need to be hospitalized. About 14% of our youth do need to be hospitalized. The team that is out there facilitates that hospitalization. So they stay with that family, they find the bed, they make sure that the hospital accepts, and they make sure that transportation is secured for that family before we leave the family. And then we follow up with the hospital to make sure that that youth has been there, that they have been admitted, and that everything is okay. Most of our youth do not go into hospitalization, but they go into our 30 to 45 day stabilization process, our intensive stabilization services, where we can be in the home for 30 to 45 days, 2, 3, 4, 5 times a week, if that's what is warranted, to continue to stabilize this youth and this family. Some of our youth come in with supports, and it could be that they don't see their therapist for another week, so we will stay on and provide stabilization for that week to make sure that they're safe and stable until they get back to their provider. And then some families decline any ongoing services. During that time when we're in the home, we're doing very brief short-term interventions. We're stabilizing. The psychiatric caseworker continues to work on any of those needs and supports that the family may have. They're working on how to link them to ongoing services. They're working on any school issues. We always make a referral to, if the family wants it, to our family partner, Nevada PEP. So we're linking them very early on with peer family support. And then at every session that we have, we review and update that safety plan that we did in the first meeting. How it works in rurals, we receive the call in Las Vegas, we triage and we send it to the rurals. The rural picks that up within 5 minutes typically, sometimes 10 minutes. And within minutes of that, that rural team member is calling the family or the referral source and connecting. How they do that in the rurals is all through telemed. They have a platform called VSEE, V-S-E-E. It's a HIPAA compliant free app that they use. And so they're set up, the clinicians are, where are their clinicians located? I think one's in the rural, one might be in Las Vegas, but they're spread out. They have 3 clinicians across the state. Rural responses are fully telemed on the part of the clinician. They then partner with psychiatric caseworkers who sit in the rural areas under the adult system who do the psychiatric caseworker piece for them. So the clinicians do not have to be in the rural areas. The families can use VC on their phones or on their computers, so it's very accessible for youth and families to be able to access this platform for the response. And then the rest of their system is the same for them. They do the same assessments, the same safety planning, they just do it all by video. Any questions about that system? Yeah.
Maybe the slide in the one before, when psychiatric inpatient is needed, is it that response team that can make that decision alone, whether it's voluntary or involuntary?
Yes. Okay. So the response team makes the recommendation. The families have to agree. We've yet to have a family say no to that in the 5 years that we've been doing this. We've come close and we've talked with families. Sometimes the doctors will overrule us when we say no in the hospital setting, and that's their choice, of course. Our teams staff with a supervisor after every response. So we send them out, we know where they're going. They have to call us back and give us a very brief update about what happened and what their recommendation is. We may disagree with them sometimes and send them back in for some further clarification, but yeah.
Same decision making and responses can be made locally or through the telehealth.
Yes.
Even involuntary.
Yes.
Done that way.
It can. Yeah. It's a little trickier for hospitalizations in the rurals because there's fewer places for them to go, so it's a little more difficult, but the same process. Yep. Their team facilitates that. My rural partner wanted to make sure that you had a visual of what it looked like to use telemed, so this is her slide on VC. So we talked about the crisis assessment tool and the crisis needs assessment already. Here's what our safety plan looks like. So we're doing this initially with the youth, and then we come back together with the caretaker to review it and to add anything else to it in that conversation. But you'll see we talk about what are some of their behaviors, what are some triggers that they're self-identifying in different areas. Then we have them write in what are some warning signs, what are some of their coping skills. We give them a list of numbers so that this can be up on their refrigerator in their bedroom, on their bathroom window, whatever it is that's helpful for them to be able to review it. And then what is unique, we think, to our safety plans is we talk with them about what needs to happen to make your environment safe for you. How can your parent or caregiver help you? And what is one thing that is most important to them and what is worth living for? So we have that conversation with them and we have it on their safety plan. And like I mentioned a minute ago, we review this all the time because what we get in the initial is not necessarily what we're gonna get 2 weeks in when youth are more comfortable with us. We talked about this already, so we can skip it. I sometimes forget where my slides are in order, so sorry about that. So 61% of our youth go on to that stabilization services that we talked about. Okay. Rural looks a little bit different than the urbans. Our rural referral sources are often the schools in the school district, parents, and then the juvenile justice system. You'll see that in the rurals, only 5% of the youth present at the emergency departments compared to the urban areas, which is much larger. Schools in Reno, again, are the highest referring source. Our partnerships with the schools are very strong up in Reno. And then in Las Vegas, emergency departments and schools are our two top areas in which we call. So you can imagine, since schools are our biggest referral source, that in the summers we're quite slow in mobile. And on breaks, actually, we're slow as well. So we respond for these reasons. Most often we get calls regarding suicidal ideation, suicidal attempts, suicidal behavior, suicidal thoughts, behavioral issues, parent conflict. We do have some self-injury, homicidal ideation, and you know, the list. Interestingly, when we get out there, this is not actually what we see all the time. These are just the issues that we get the initial on the screener. We find that things look much different. There's a lot of bullying and a lot of peer conflict. The suicidal ideation is often triggered by something else. Youth have lost a privilege at home, for example, and say they're going to kill themselves, and that triggers a call to us. So we're finding lots of things when we get out there. So like other systems, when somebody calls us, we go, right? So this is less important to us. We track it, but it's less important to us because we're going to respond regardless of why you're calling. Where we respond, emergency departments, houses. We do have families that often choose to come into our office for a variety of reasons. Most often it's because they're living in situations with other family members and they don't want us necessarily in that home. We do respond to the schools quite a bit and some of our community partners. We track hotline calls because it helps with staffing of our programs. We peak on Tuesday and Wednesday, which I find very interesting. And on the weekends, we don't get a lot of response calls, but we have a lot of stabilization appointments on the weekends. So those look a little different. We also track what time our calls come in. So we're very busy between 10 a.m. and 2 p.m. That makes sense if schools is one of our biggest referring sources and emergency departments, right? Because kids have been at school now for a couple of hours and things are starting to escalate, or they've had time to make it into the emergency departments between those hours. Okay, funding. I know this is a hot topic, right? So Nevada is unique in that all our positions are state-funded positions, and in the rurals right now they're contract positions. So in Washoe and in Clark, all the positions that we have are state workers. So we are direct service providers with the state of Nevada. We're one of the only states that are still doing direct service provision. So we are funded through Funds for Healthy Nevada, the tobacco settlement. About 50% of our funding came from that. That's how we initially got started, is we had this pot of money from the tobacco settlement, and we developed mobile out of that. We have some state general fund and some federal funds. The rural was initially funded through the System of Care Expansion Grant, and they are currently working on how they're going to sustain that. Nevada's legislature only meets every other year for 4 months, so it's in, right? So it's in their budget, it's in their proposal to make these state positions as they move forward in the rules. That's important too, that we only meet every other year, because when I talked about how quickly we expanded in the beginning, we expanded outside of a legislative session. So because of the responses and the feedback that people in politics were getting regarding our services, that we were able to get positions through interim committees, which is almost unheard of in Nevada. We also have some Medicaid billing codes that allow us to bill for telehealth. So that's how the rural is billing as well. We respond regardless of insurance status. So while we ask the questions so that we know who is coming through our door, we will respond to you if you're insured, uninsured, Medicaid, private insurance. A lot of you have asked so far about what staffing looks like. This is what our staffing patterns look like in Nevada. In Las Vegas, we have about 30 staff. In Reno, they have 5 teams, so 5 psychiatric caseworkers, 5 clinicians. In the rurals, they have 3 clinicians, but they partner with those 25 psychiatric caseworkers to make up their teams. Reno is running not 24/7, they're running about a 10-hour shift, and rurals are running 9 hours, 7 days a week. But we do answer their calls 24/7. Training also, I've heard a lot of questions about training, so here's what we do in terms of our formal training: motivational interviewing, trauma-informed care, the crisis assessment tool, much like the CANS, you have to be certified on every year, so they're certified on that every year. The crisis needs assessment is something that we created in Nevada. It came out of our wraparound programs and their old targeted case management assessments. We had to change the name of it to meet Medicaid requirements, but it's essentially a similar tool. Trauma-focused CBT, brief solution-focused CSEC, which is the sexual trafficking. We have quite a bit of that in Nevada, and quite a few kids come through mobile with that concern. So we're just kind of digging into that and starting to train on that and raise our awareness on that. Ethics, safety planning, because we do so much work on our safety planning. We do formal safety planning training and lots of training when the safety plans come back. You might have noticed that supervisors have to sign off on those safety plans. It's a great supervision tool when we're meeting with our teams to look at how they're doing on their safety plan. Is it helpful to families? Is there other things that could have been looked at? Suicide awareness training, field safety. We partner with our juvenile justice program to come in and do some field safety for our teams, because we're out in families' homes and in communities and at 3 in the morning and things like that. So we do field safety training, cultural logistics, LGBTQ, and our SOC values and principles. And then lots and lots of live training, shadowing, and coaching. So when a new team member comes on board, they shadow a lot. Then they are shadowed within the team as they do that. And then we do ongoing, at least quarterly, where we are going out and doing some live coaching in the field with our teams. Our system partners, we've talked a little bit about as we started to build. We have our regional and state consortia on board. Our emergency departments were very, very helpful to us and still are in terms of being partners. School district was probably our biggest champion when we rolled out. They were very invested in this happening. And that has come a little bit full circle now that school district has rolled out in Nevada something called Safe Voice. Do you guys have anything like that in your states? A system where kids can text, email, or call in concerns, reports, bullying, suicidal ideation, and that just rolled out this year, and it is blowing up in Nevada, and it's a bigger capacity than they can handle. So we are in conversations with them about which calls they might get that would be better served by the mobile response team, and how we're going to get those calls sent to us instead of having their teams respond. So we're in those conversations right now as kind of the next evolution for us in Nevada. Faith-based law enforcement, JJ. And of course, our family support network's been very involved every step of the way with us. This is our family support network, providing peer family support. I just checked in with them on their funding. I think somebody asked that today. They are not contracted with us. Well, they are kind of, but they're not a state employee, and so they are funded by federal grants and state grants, is what she told me. So it is not in our Medicaid chapter for family support reimbursement, so they did not get reimbursement through Medicaid. So we, in terms of quality measures, we do consumer satisfaction surveys as well. We do that at the 7-day mark, and then later on, about 2 months out, we're checking back in with families, asking how things are going. Are kids still involved in services? Do you need anything else from us at this point? What was your experience? We do quarterly chart reviews, and then like I mentioned, we're doing that live coaching as well. Clinical oversight for our program, supervisors review every step of the way. So a call comes in, a team lets us know what the call is, what we're going out on, and where they're headed. So we know where they are and what kind of calls they're going out on. We sign off on the intervention screenings. Before a team can leave a response, they have to call us back and let us know what the plan was, right, for this family and who's agreed to it. We look at the safety plans when they come back in, and then we review with the staff when they come back in for a couple of reasons. One being debriefing and support for that team when they come back in. Thanks. Supervisors review and sign off on all our treatment plans. That's a state regulation that supervisors have to sign off on treatment plans, so we do that as well. And then we do the live coaching. So our outputs, and we look at what we did. So what are our demographics? What types of calls? You guys saw that data at the time the calls came in, what we're getting called for, who's referring to us. And then we look at the numbers for our stabilization and what the outcomes of our interventions were. We want to look at how we helped. So these are a little bit harder to quantify, right? But we look at safety planning. We're asking families, I'll get to that part. Who are we connecting them with? What are the changes in the CAT? So somebody asked how we track CAT outcomes. So we are looking at changes from initial to discharge, especially on those stabilization cases, because we've been in for 45 days potentially. 1 week after, we do client satisfaction. And this is 3 to 4 months, but I think we're doing it at more 2 to 3 months for that long-term outcome. Here's an example in your PowerPoint of what our satisfaction questions are. We've actually changed this a little bit. We changed the question since I did this. We wanted to know on a safety plan, were you involved in it? Like, was your input to both the parents and the youth? Did we hear you when you said what you wanted on your safety plan? Did you feel comfortable when we left that you had a plan to move forward with? So we're asking those questions now. We're just starting those questions. And then the long-term outcomes. So 2 to 4 months post-discharge, about 7% of our youth go back into the emergency room for mental health reasons. I don't really like that number either. I would like to see that they're calling us back or calling who they're connected to, but we'll take 7% given what our numbers looked like 5 years ago for kids presenting. 9% have been admitted to a psychiatric hospital since we last saw them, and about 58+% are still in services. And that's it. I went way fast. All right, way fast. Questions? Yeah.
You mentioned there's no, I think, central call
Right.
center, bouncing to staff phones, cell phones, things like that.
Yeah.
Does every region have their own phone number to call that bounces to the local provider, or is it one statewide number that somehow behind the scenes hits the local?
It's 2 numbers. So Washoe County has a number, Reno, and then the rest of the state has a different number. Right. So Las Vegas fields the rural numbers so that they didn't have to try and man and have their own phone number. Yep. Yeah.
You mentioned the issue in with the law enforcement being on scene and they just plain Baker Act them. Is there a list of protocol questions that you can provide to law enforcement that would allow them to, if the scene is secure and it's not truly a Baker Act thing, where they can do a couple check boxes for the basic questions you do to see if it's stabilized enough where they can leave, and if needed, the family can call them back before you get there?
Yes, we've been working with law enforcement on that, and some of them do that. And if it is stable, if they do stabilize it, they will give our number, and we will go out after. We just haven't fixed it yet, so there's a lot of work still to be done, and that's a good idea. That checklist.
Do you have those questions out yet, or is it something you're still developing?
We don't have them out to them, no. But we do have CIT trained officers in Las Vegas. They just aren't always the ones responding to the calls.
You're familiar
Yeah.
with CIT, crisis intervention training for law enforcement?
Yeah.
Age ranging, sorry, I don't think
Oh, I don't think I told you, birth to 18.
birth to 18.
And we will see 18-year-olds if they're still in school. So those high school seniors that are 18, we can see, but outside of that, per the mandate in the state, we aren't allowed to see kids over that.
And so this whole program is
Say it again.
This whole program of crisis response is administered and coordinated by your Department of Mental Health at the state level.
The Division of Child and Family Services.
Okay.
Yes.
Oh, okay.
Yeah.
And so you have a very specific unit that is running it and overseeing it.
Right. So the Mobile Crisis Response Team is within the Division of Child and Family Services, which is under the state. Yep.
Is there interaction with your entity that oversees home and community-based services for kids with developmental disabilities?
It is a sister agency. It is definitely a need for us to be able to do that better, not just from mobile, but within the entire state. So those youth are really tough in Nevada, I think in the whole country actually. I'm noticing that people are struggling with how those dually diagnosed kids, the DD kids and the mental health kids, they tend to bounce, right? It's not a mental health issue, it's a DD issue. It's not a DD issue, it's a mental health issue. So that is happening in Nevada as well, and we're really trying to figure out how to coordinate better between the agency that does the IDD work and the mental health work.
I see.
Yeah.
So you really siloed.
That we are two different agencies. Two different agencies under the same department,
Yeah.
but definitely two different agencies. Yes. Yeah, sadly. Yeah. Did you have another one?
I'm just thinking about funding or payment, given that it sounds like it's a state position.
Yeah.
Is it pretty consistent in terms of how staff are paid across the system, or is there a difference between the rural and the
Nope, it's
because the rural aren't necessarily responding in person, it's all iPad?
It's all the same. The only difference is that the rural positions are contract positions, so they don't have the state, yes, thank you, yet. But if they do get funding and they're made state positions, then they will all be state positions. Yeah. The benefit to that for me, because I run the outpatient mental health as well in my region, was that as mobile grew, I was able to move positions, which is how I ended up with so many in Las Vegas, is I didn't even have to beg or borrow, I just stole them from my own programs, and I reallocated them to where they were needed is what happened. So I was able to get a lot more positions than I was funded for initially by reallocating them to where the need was. So, any other questions? All right, thank you.